If you're over the age of 50 and you've recently developed aching shoulders, stiffness in your hips, difficulty getting out of bed in the morning, or pain that seems to have appeared out of nowhere, this video could be extremely important for you. Many people assume these symptoms are simply part of getting older, arthritis, or general wear and tear. However, there is another condition that is commonly missed and often misunderstood called Polymyalgia Rheumatica, or PMR for short. PMR is one of the most common inflammatory conditions affecting older adults, yet many people have never heard of it. In fact, I regularly see patients who have been struggling for months before finally receiving the correct diagnosis. The good news is that PMR is usually very treatable once recognized. In this video, I'll explain exactly what PMR is, the symptoms you should never ignore, how it is diagnosed, the link with giant cell arteritis, and what treatment involves. I'm Dr. Naveen Bhadauria, consultant rheumatologist at Pure Rheumatology London. Let's start with the basics. Polymyalgia rheumatica is an inflammatory condition that typically affects people over the age of 50, with the average age at diagnosis usually being around 70. It is very unusual to develop PMR before the age of 50. The condition causes inflammation around the joints and soft tissues, particularly around the shoulders, neck, hips, and upper thighs. One of the biggest misconceptions about PMR is that people think it affects the muscles themselves. In reality, the inflammation is often around the joints, bursa, and surrounding structures rather than within the muscles. The result, however, is profound aching, pain, and stiffness that can make even simple daily activities difficult. One of the hallmark symptoms of PMR is shoulder pain and stiffness. Patients often tell me that both shoulders suddenly became painful over a matter of days or weeks. They struggle to lift their arms above their head, reach into cupboards, wash their hair, or put on clothing. The stiffness is often particularly severe first thing in the morning. Morning stiffness is one of the most important clues. Patients may feel stiff for 30 minutes, an hour, or sometimes several hours after waking. Many describe feeling as though they have aged overnight. They wake up feeling locked up and find it difficult to get moving. The hips are another very common area affected. Patients often report pain around the buttocks, hips, or upper thighs. Some describe difficulty getting out of a chair, climbing stairs, or getting out of bed. Others notice they cannot walk as comfortably as before because their legs feel stiff and painful. Now, one important point is that PMR usually affects both sides of the body. If somebody develops sudden pain and stiffness affecting both shoulders and both hips, that immediately raises suspicion for PMR. Another common symptom is fatigue. Many patients feel exhausted. They may sleep well, yet wake up feeling tired. Some report reduced energy levels, loss of stamina, and a general feeling of being unwell. This can sometimes be accompanied by low-grade fevers, loss of appetite, or unintended weight loss. Now, this is where things become interesting because PMR can sometimes be confused with other conditions. Many patients initially wonder whether they have osteoarthritis. Others worry they may have rheumatoid arthritis, fibromyalgia, or even a muscle disease. Unlike osteoarthritis, PMR tends to come on relatively quickly. It also causes much more prominent morning stiffness. Unlike rheumatoid arthritis, PMR does not usually cause significant swelling of the small joints of the hands and feet. And unlike muscle diseases, muscle strength is usually preserved, even though patients may feel weak because movement is painful. When we assess someone with possible PMR, the history is often extremely important. The pattern of symptoms frequently provides major clues. We then perform blood tests, particularly inflammatory markers such as ESR and CRP. In many patients, these are significantly elevated, reflecting active inflammation. However, one important point is that not every patient with PMR has dramatically abnormal blood tests. Occasionally, inflammatory markers can be only mildly elevated or even normal. This is why diagnosis should never solely rely on blood tests. Ultrasound can sometimes be extremely helpful. We often see inflammation around the shoulder bursa, hip bursa, and surrounding soft tissues. In certain situations, MRI or PET scanning may also be used. Now, perhaps the most remarkable feature of PMR is how dramatically patients often respond to treatment. The main treatment is corticosteroids, usually prednisolone. Patients frequently describe a remarkable improvement within days. Some even tell me they feel like a completely different person after starting treatment. This dramatic response can actually help support the diagnosis. When someone with classical PMR symptoms experiences a significant improvement after starting steroids, it increases our confidence that we are dealing with PMR. However, treatment is not quite as simple as taking steroids for a few weeks. PMR often requires a gradual steroid taper over many months and sometimes years. If steroids are reduced too quickly, symptoms can return. One of the biggest challenges in managing PMR is balancing symptom control against potential steroid side effects. Long-term steroid use can increase the risk of osteoporosis, diabetes, weight gain, elevated blood pressure, cataracts, and infections. This is why patients require careful monitoring. Because of this risk, we often think about bone protection from the very beginning. Calcium, vitamin D, and osteoporosis treatments may sometimes be required depending on the individual patient's risk factors. Now, there is another reason PMR is such an important condition to recognize. Around 10 to 20% of patients may develop a related condition called Giant Cell Arteritis, often abbreviated to GCA. This is a medical emergency because GCA can affect blood vessels supplying the eyes and brain. Symptoms may include new headaches, scalp tenderness, jaw pain when chewing, double vision, or sudden visual disturbance. If somebody with PMR develops any of these symptoms, they should seek urgent medical attention. Prompt treatment is essential because untreated GCA can lead to permanent visual loss. In fact, sometimes PMR and GCA occur together. This is one reason why rheumatologists always ask patients about headache symptoms and visual symptoms when assessing possible PMR. Now let's talk about prognosis, because this is often one of the first questions patients ask. The good news is that most patients do extremely well. The majority eventually achieve remission and can come off treatment entirely. However, relapses can occur, particularly during steroid reduction. Regular follow-up is therefore important. We monitor symptoms, inflammatory markers, and potential treatment side effects. The aim is always to use the lowest effective steroid dose while maintaining good symptom control. Another question I'm frequently asked is whether lifestyle changes can help. Whilst lifestyle changes do not replace medical treatment, maintaining physical activity, preserving muscle strength, eating a balanced diet, and protecting bone health are all important aspects of long-term management. Patients often worry that movement may worsen the condition. In reality, gentle movement is usually beneficial. Many people find that once treatment begins and inflammation settles, they can gradually return to their normal activities. Now let's summarize the key warning signs. If you are over the age of 50 and have developed new shoulder pain, hip pain, profound morning stiffness, difficulty getting dressed, difficulty getting out of bed, unexplained fatigue, or elevated inflammatory markers, PMR should absolutely be considered. If these symptoms are accompanied by headaches, jaw pain, scalp tenderness, or visual symptoms, urgent assessment is required because of the possibility of giant cell arteritis. The most important message I want you to take away from this video is that PMR is common, frequently missed, and usually highly treatable. Many people suffer unnecessarily because they assume their symptoms are simply due to aging. If the symptoms I've described sound familiar, it's worth discussing them with your GP or seeing a rheumatologist. Early diagnosis can dramatically improve quality of life and help patients return to normal activities much more quickly. If you found this video helpful, please like, subscribe, and share it with anyone who may benefit. For more videos on arthritis, autoimmune disease, osteoporosis, and rheumatology, make sure you subscribe to the channel. And if you would like a specialist assessment, I see patients at Pure Rheumatology London. Thank you very much for watching.